you. So thank you for the opportunity to present some recent research on our results led by Professor David Bennett and Professor Sudarshini at Oxford. I'm talking a little bit about patients who have autoantibodies against leucine-rich glioma inactivated 1 or LGI1 and contact-associated protein 2 or CASPR2. And specifically looking at patients with these autoantibodies who normally have an autoimmune encephalitis syndrome. And in a proportion of patients, they also have described peripheral nerve hyperexcitability and dysautonomia. Pain has been described in a minority of patients, but to date not been well characterized. So our main goal was to systematically review and characterize the clinical features and the treatment response of a cohort of about 147 patients with LGI1 and CASPR2 antibodies who also had and determine the proportion of patients who had pain, and also explore underlying pathophysiological mechanisms in these disease groups. So we identified that of the patients, of the 147 patients, 17 out of 33, so about 52% of patients with CASPR2 antibodies, and 20 out of 108, so about 19% of the patients with LGI1 antibodies experienced pain at some time in their disease course. And in 76% of patients, the onset of pain was actually concurrent with the onset of central nervous system manifestations, such as those demonstrated over here. We classify these patients as having neuropathic pain if they fulfilled a validated questionnaire, the DN4 score, and in the absence of a physical examination, if they had a score of 3 or greater, they were classified as neuropathic pain. And we identified that 60% of the LGI1 antibody positive patients with pain and 90% of the CASPR2 antibody positive patients with pain had neuropathic pain. 2/3 of these had normal nerve conduction studies, and of interest, 18% of these patients at various points were given prior diagnosis of fibromyalgia or functional pain. When we looked at the distribution of their pain, both groups tended to have a length-dependent neuropathy with dominant hand and feet involvement, as you can see here. But intriguingly, the LGI1 patients, 45% of patients had truncal involvement, which was present in none of the CASPR2 antibody-positive patients. When we looked at therapeutic response, you can see over here that the response to conventional analgesia, so specifically anti-inflammatory medication or neuropathic pain medication in both groups, LGI1 and CASPR2 antibody positives, didn't differ too much. So about half of them in each group had no response and half had improvement. Of particular interest, when we looked at response to immunotherapy trials, 82% of the LGI1 antibody positive patients had an improvement in their pain compared to only 38% of the CASPR2 antibody positive patients. We performed telephone interviews with the patients to obtain a patient-reported outcome measurement information system, or PROMIS, to look at the pain interference scale, where a rate of 40 is maximum pain interference and a rate of 8 is minimum. And we characterized this both at the nadir of pain and post-immunotherapy, and identified that there was a significant reduction in pain interference in LGI1 antibody-positive patients following immunotherapy. However, the CASPR2 antibody patients didn't respond quite as well. And this response was dominated by those who were classified as having neuropathic pain compared to those who were classified as having unlikely neuropathic pain. Of interest, when we follow them up to latest follow-up, which was a median follow-up of 5 years in both groups, this reduction in the pain interference scale in the LGI1 antibody-positive group was sustained at latest follow-up, and this was not the case for the CASPR2 antibody-positive patients. And then when we use something called the EQ5D5L, looking at different domains of functional impairment, patients with LGI1 antibodies and neuropathic pain more commonly had no impairment in domains including mobility, usual activities, and anxiety and depression, whereas the patients with CASPR2 antibodies had significant impairment in these domains. Lastly, we tried to look at the underlying pathophysiological processes here. We were intrigued to identify that patients who had both CASPR2 and LGI1 antibodies and scored highly on their neuropathic pain scales had reduced intraepidermal nerve fiber densities, compared to the median and range for age and gender matched controls, whereas obviously healthy controls and patients who had CASPR2 or LGI1 antibodies but didn't fulfill criteria for neuropathic pain had these intraepidermal nerve fiber densities in the normal range. And here in a healthy control, you can see the nerve fibers crossing the dermoepidermal junction, and this is absent in one of our CASPR2 antibody-positive neuropathic pain patients. We then evaluated binding of the CASPR2 and LGI1 IgG in patients in our cohort, as well as healthy controls and patients who had LGI1 or CASPR2 antibodies who didn't have pain. And we used two in vitro culture systems, and this included human iPSC sensory neurons, which were myelinated with Schwann cells, and then also included murine dorsal root ganglion cultures. And we identified that a high proportion of those with CASPR2 antibodies bound specifically to unmyelinated human sensory neurons, whereas none of the LGI1 or healthy control patients did. With a similar pattern, a significant proportion of CASPR2 antibody-positive patients bound to the dorsal root ganglion cultures, not present to that degree in LGI1 patients. And importantly, this binding was abrogated when we used DRGs from a CASPR2 knockout mouse. So in conclusion, we identified that patients with both these disease groups may experience neuropathic pain, which has a significant impairment on function, particularly in the CASPR2 antibody-positive patients. The LGI1 antibody-positive patients with neuropathic pain appear to have a more prominent immunotherapy responsiveness. And the pain in these two disorders may be mediated by differential underlying mechanisms. Thank you.
Thank you very much. It was a very interesting talk.